Well, I'll go ahead. I'm Laura White. I'm a professor of biostatistics, and Kauko and I are really thrilled to have Sara Del Valle with us today from Los Alamos. Really appreciate her taking the time to come and speak with us. This is originally going to be in person, but due to complicating factors, we had to move this online. I really appreciate Sarah's flexibility in accommodating all of this. So it's my great pleasure to introduce Sara today. Sara Del Valle is an applied mathematician. She is at Los Alamos National Laboratory and leads the fusion team. So she does a lot of work doing really computationally intensive models that really try to understand human behavior, as well as a lot of other satellite imagery and other things, bringing those together to really try and understand infectious disease dynamics and their impact on humans more carefully. She's done a lot of work in COVID-19 and throughout the years in various infectious diseases. So really is really furthered the field in agent-based modeling, and we're just really thrilled that she's willing to join us today and share some of her experience. So turn it over to you, Sara. Thanks again.
Thank you, Laura. Thank you for the invitation. And so let me share my slides now. Okay, can everyone see them? And I'll put it on presenter mode. Okay. Can you see my slides and everything?
Yes, we can see that.
Okay, great. Well, thanks again for the invitation, and I'm excited to talk to you about some of the work that we've been doing here. And yeah, I'm sorry that I wasn't able to make it in person, but I hope that in the future I'll be able to visit in person. Okay, so let me just get started. And I wanted to start with the motivation. I don't really know the audience necessarily, and so I hope that maybe I might be preaching to the choir, but this is one of the things that kind of motivated our work, although we had been thinking about these challenges before. But we conducted a survey of about 80 academics, public health practitioners, and decision makers. And there's also the surveys are actually in this paper that recently came out at BMC Global Public Health. And there were a lot of challenges and gaps and opportunities that we learned from these experts. But one of the major gaps that we heard from decision makers was the lack of real world complexity in a lot of the models that they were using for COVID-19 pandemic. And specifically, they mentioned some of the questions that they wanted to answer during the pandemic, and they didn't really have the tools to answer those questions. And so why model complexity matters, we want to capture population heterogeneity, behavioral feedback, and adaptive responses. As many of you know, during the COVID-19 pandemic, there were a lot of changes in policies and also compliance rates, and so the feedback between the policies and the intervention strategies and what people were doing were not really well captured in models. Also, modeling interventions at a fine scale. This is something that we learned from decision makers. They wanted us to explore interventions for this particular district or for this particular restaurant or bar. And so sometimes we didn't really have the level of complexity. We didn't have restaurants in our models, and so we couldn't really measure the impact of closures for those types of questions. And then also evaluating the interaction effects between multiple interventions. Most of our models kind of captured, some interventions, but not all of them. And so having this like multi-objective kind of approach would be super useful for decision makers. And ultimately, I think the reason why we're trying to add complexity and address certain things in our models is because we want to provide real-time decision support, and hopefully some of the work that we're doing is moving us in that direction. So the major challenge is that we have a lot of models, and if you look at the literature, from the last 50 years, the majority of the models available to us are in the compartmental kind of model area. And so while we have a lot of different tools, most epidemic modelers kind of use compartmental models. And while these models have been super useful in helping us get insights and understand how disease spreads in a population, they often assume homogeneous mixing, meaning that everyone is mixing with everybody at the same rate. And so then they don't really capture the complexity that we need. And so, this is just a very brief kind of example of how they use a system of differential equations. You kind of break the population into various different compartments, and then you can estimate the rate at which people are moving from one compartment to the other. And so when you have this system of differential equations, you can basically, kind of simulate the spread of disease in a community. But this is basically what the homogeneous mixing approach is telling you, is that everyone is connected to everybody. And so you will see very fast spreading dynamics in your models. We also have, other types of models, from spatial models, metapopulation models, network models, and specifically metapopulation models are able to capture a little bit more complexity, such as, demographic patterns or spatial patterns. You can model the spread of disease between two counties or two communities, but you're still assuming homogeneous mixing within each of those communities, and only the movement between the two different communities is assumed to be heterogeneous. So while this is able to capture a little bit more of what we see in the real world, we're still not really able to capture the complexity and answer some of the questions that decision makers had during the pandemic. So for that reason, we are trying to model population heterogeneity through agent-based models, and I'll go into more detail now. Okay, so another motivation for the changes that we made into our ABM was that we saw certain communities had disproportionate impacts compared to the rest of the population. And this kind of highlights some of the some of the assumptions that we made, and not just the assumptions, but also some of the changes that we made in our model. So we know that Latinx, Black, and American Indian communities had worse outcomes than other populations. And specifically here, this is a figure of new COVID-19 cases in New Mexico. And while the Native American, Indian, and Alaska Native populations in New Mexico only makes up about 10% of the population, during the early phases of the COVID-19 pandemic, they were making over, nearly 70% of the cases. And so you can see the Native American epidemic curve here in Black. And so clearly, there was something driving this massive spread in those communities. You can also see the Hispanic communities in here in kind of pink, and then you have other, like, white in blue, and then other racial populations in other colors. And so this is just a specific example of New Mexico, but also if you see across other areas, and also this is for the entire United States, you can see that Blacks had disproportionate number of deaths, and also Indigenous, Pacific Islanders, and Latinx. And so clearly there, we wanted to understand some of the drivers and see if we are able to capture some of these disparities in our models, because previously we were able to simulate the spatial heterogeneity, but not really at this level. So our overarching goal was to evaluate how socio-demographic heterogeneity and exposure risk kind of shape population disparities, and particularly the role of racial and ethnic differences in infection rate. So in order to accomplish this, we had to make a lot of changes to our agent-based model, and I guess I don't know that I included a very high level overview of what an agent-based model is, but basically an agent-based model is a computational simulation similar to a video game, basically, where you have the entire United States and you have agents, and so that's why it's called agent-based model. So each person in the simulation is an agent, and then you can kind of follow these agents as they move across the space, which is, you know, their county, their state, or the United States, and when they go to school and they go to work, and et cetera. And I will show a little bit of that later, but this is at a very high level. So previously, our model had a very old population, and so we were using the 2000 U.S. Census data to kind of inform the model. We were using genetic assignments and more homogeneous kind of transmission rates, and kind of limited interventions. But in the new model, we used the 2019 U.S. Census data to inform the population in our simulation. And in addition to using that, we're adding 25 attributes, and these are demographic attributes, which I'll show a little bit in a second, via Urban Pop. And Urban Pop is a data set that is developed by Oak Ridge National Lab, and these are the same team that creates a lot of different data products for the community. We also have a lot more structured classrooms, and I'll go into a little bit more detail later, and for teachers and also occupations, and so that we can capture the real world better, and industry-specific contact scaling, which I'll describe in just a second. And then we have very kind of targeted interventions. You can do it at the county, at the industry level, or even district level closures, for example, for school. And our paper that we'll be describing, EPICAS 2.0, will be posted, I think, on arXiv this week. Okay, so I mentioned the synthetic population. That was the first kind of change that we made. And here's a sample of all of the demographics. We have 25 demographics, but this is just kind of a very high level overview so that you can get a sense of like the level of detail that went into this new version. And so we have, you know, various types of income and household size. We used to have household size before, but I think we have a more detailed now granularity in terms of household size. We have, you know, children, age, race, which is also important for the type of work that we were interested in doing, and ethnicity, income poverty level, etc. Oh, and NAICS codes, which is the National North American Industry Classification System, which is basically how occupations are stratified across the U.S. population. Okay, so then the other major change that we made in order to be able to do the analysis that I'm going to be showing to you today is also this like structured classroom and teachers and occupations. And so basically for schools, we have different types of schools, you know, high school, middle school, elementary school, kindergarten, and preschool. Sorry for the typo there. And so instead of using kind of like an average student teacher ratio for the different school types, each of these school types have a student teacher ratio that is derived from the county level information. So we have more heterogeneity and granularity. And then for workplaces, we have industry stratification. I mentioned the NAICS codes, which is the National North American Industry Classification System, and we're using the 3-digit NAICS codes. And once you are assigned a NAICS code, for example, you're a nurse, then we also stratify your contacts by work groups. So industries are subdivided into work groups based on national labor surveys. And then we have another kind of parameter that is able to kind of capture the intensity. So it's basically worker to worker interaction or work in public interaction. So for industries that have a lot of public facing, such as retail, for example, we have this worker public interaction that's greater, but for worker worker interaction, if you're in a if you're a scientist, for example, maybe you don't really have a lot of the worker public interaction, but you might have more worker worker interaction. And so this, all of these kind of changes and updates were able to kind of help us do some studies that I'm going to be showing. Okay, so here's also the simulation at a very high level. Basically, you start with the population. I mentioned we have 25 demographic characteristics now, and some of the new ones that we didn't have previously include race, ethnicity, school grade. And so you come up with a very diverse synthetic population. Then the next thing in the simulation is the locations. And so we have, we basically have 2 time steps. We have a daytime time step and a nighttime. And so during the day, the agents can go to work or school or some other community level activities. And then during the nighttime, they're usually home, except for some workers who might work in do night shifts. And so we basically kind of have a network construction based on these interactions, and so that we're able to capture the co-locations of agents in all of these different venues or communities, and then that results into we also add the transmission model and the travel mode. So people are moving from their daytime activities to their nighttime or during the day during various activities. And so then you're able to simulate the disease spread in this setting. Okay, so that's basically the setup of the agent-based model that we're going to be using to explore how different demographic assumptions contribute to disease spread, because we wanted to kind of understand what were some of the drivers that led to disproportionate impact to certain populations. Okay, so one of the things that we wanted to explore was, as a potential driver of heterogeneity, was employment type. And we know from the literature that exposure risk varies by industry, work group size, and role. I mentioned the public-facing jobs, such as retail or restaurants, and also high contact roles, such as nurses, facing higher transmission risk. And to explore this, instead of doing a study for the entire United States, we focus on New York. And so here you have employment in hospitals. And so you have the employees broken up by different demographic characteristics, and this is race and ethnicity. So you see, the largest proportion of workers in hospitals in New York are Hispanic, followed by Asian and Black. And so you can see kind of other race and ethnicities here. And so this is for hospitals. And then if you look at food services and drinking places, you also see that the majority are Hispanic, followed by Asian. And then you see other races and ethnicities here. Also here we have nursing and residential care facilities, and so the majority are Black. And then here we have professional scientific and technical services, for example. And so you see also that the majority of people in those industries are Asian and white. So employment type was one driver that we're going to explore as a potential contributor to the disparities. The other potential driver was student-teacher ratios, and this is Florida. And so student-teacher ratios and school group size influence exposure risk. And so we wanted to see how this could potentially contribute to what we saw in Florida. This is the mean student-teacher ratio across Florida, and then this is for just Hispanic students. And here you see a very weak correlation between student-teacher ratio and Hispanic students. It's about an R of 0.37. So maybe this is kind of telling you that this might not be a very large contributor, but we will see once we do the actual analysis. And then finally, the third driver that we wanted to explore was household size. And we know that there's several studies that, including some of our own studies, have highlighted the impact of household size as a key factor of disease transmission. And so here I have a figure showing the mean household size in New Mexico by race and ethnicity. And so you have non-Hispanic Native American people in all the way in the top, and then followed by Hispanic multiple, and then white communities. And so you can see, we wanted to see how this could potentially be contributing. Okay, so we performed different experiments, and the first experiment was, as I mentioned, we wanted to see the contribution of the workplace. And so we, in New York City, we basically used two different models within our same agent-based model. In one model, which is, we call it Model 3, we use the work assignments based on the data from that we have NAICS information that is provided to us by the census and the Department of labor and et cetera, that you're actually using the real data from New York City. And then in the other model, which is it was a modification of the model, we decided to assign work or industry or occupations to our agents at random. And so we wanted to see, if anyone has regardless of their race or ethnicity, has an equal chance of working, at being a scientist or working at a restaurant or working at a hospital. We wanted to see, you will be able to see the contribution of the actual data into disease dynamics. Okay, the second experiment that we performed was we wanted to see the impact of student-teacher ratio in the disease spread. And so we used Florida for this particular experiment. And so for this one, it was slightly different. We used the county student-teacher ratio for each of the schools and the school types. And the other model that we use, which we call it Model 2, is using the state average student-teacher ratio. So when you use the state average, you kind of remove some of the heterogeneity in certain counties that might have higher student-teacher ratio. And so we wanted to see what would happen if you do it at a more aggregate level, which is what a lot of the models do. And then finally, the third experiment that we did was to try to understand the impact of household size on disease spread. However, we didn't really have a good way to randomly assign the household size to people regardless of their race or ethnicity, because then you would have to modify some of the actual census data. And so that was a lot more difficult. And so for the final experiment, we just decided to to see how household size was potentially contributing to disease spread just by doing some kind of basic correlation analysis. Okay, so now these are the results for the employment type. As I mentioned, we had so we have two models. One is based on data, and the other one is what happens if you randomly assign occupations to everybody. So this is the first figure is showing just new cases per 100,000 residents here, and this dashed line is showing the snapshot of cases, new cases on day 62, which is shown here. And here you have the proportion of infected by different race or ethnicity. And so you can see that, the majority, I think, of the largest number of people, proportion infected is either multi-othered and Asian. So we do observe geographic heterogeneity, as I'm showing you in the map, and high infection rates across all racial ethnic groups. And so now here, I wanted to compare the two different models that I mentioned before. So we have model 1, which is the random model, and then model 3, which is based on actual data. And so and then this is the proportion living in track employing high risk industries, and then proportion infected in the workplace. And so you do see a positive relationship between employment in risk industries and workplace exposure. Basically, what we're seeing here is like higher incidence in community of color. But I want to draw your attention to the figure here in the bottom right. And so you can see that if you assign work or occupations at random, you do see an increase in the proportion infected overall in white communities, and you do see basically a lower proportion of infected in Black communities. And similarly, if you are actually using data, then you see that there's more infected people in Black communities and then in white communities. So this is basically telling us that because of your work occupation and the types of occupation that people of color have, they have a larger exposure rate in their and so they have a higher probability of infection. And so let me see, what else do I want to mention here? Okay, I think that's all I was going to mention. And so this is the proportion of proportion employed in high risk industries. So you see that there's a higher number of Black people employed in high risk industries, and the proportion of infected in the workplace is higher. Okay, so now going to our second study, which was the student-teacher ratio. And so here we're now moving to Florida, and this is the epidemic rate for Florida, the epidemic curve for Florida, and here we're showing the map of new cases on day 62, which is shown here, but at this point in time. So, hold on, my camera just stopped. Okay. So you do see okay, higher infection rates across Hispanic groups. So here, this is the proportion infected in Florida. You have multi and other ethnic and race groups. And so let's see. Okay. So when it comes to the student-teacher ratio, we didn't our study actually showed that it seems like student-teacher ratio doesn't really it's not contributing to the disproportionate impacts that we're seeing in in our basically in the impacts. And so if you look at the figure here at the bottom on the right, you can see the two types of models. I mentioned that for one model, we're using the student-teacher ratio for each county versus the state level, which was model number 2. And you can see almost identical results for both models. And so we decided to take a look at the distribution of this is school group size and the density for Hispanic and non-Hispanic students, and you can see that they're almost identical, which means that the school is not really driving the overall impacts. There might be other factors that are contributing to why we're seeing a higher proportion of infections in communities of color, but that the student-teacher ratio and heterogeneity within the school settings is not actually the main driver. And however, if you look at the proportion infected in at the school level, you do see that non-Hispanic students have actually lower proportion compared to Hispanic students. But once you look at the two different models, you actually don't see any major differences. And so while infection rates in school increases with student-teacher ratio in each census tract, the inclusion of social demographic heterogeneity produces no substantial difference in overall infection rate. Okay, and so then the final study that we explored was household size. I mentioned that there's been several studies that have shown that household size could be a driver for disease dynamics. And so we did the study in New Mexico, and this is the epidemic curve. And we're showing the new cases on day 90, which is shown here. And so if you're not familiar with New Mexico, this corner over here it's where most of the Native American it has a very high number of Native American communities in that area, and so you can see a higher number of new cases on day 90 shown there, and so here we have proportion infected. And one thing that I think I forgot to mention is that we are capturing the Hispanic population under multi because of the way we decided to plot these figures. But so you do observe geographic and racial ethnic disparities here. We see higher number of people infected in Hispanic communities and also in Native communities. And so, yeah, this is the Navajo Nation experiencing disproportionately higher incident rates, which is what we observed during the pandemic. And so if we look at the impact of household size and exposure risk, here we have the distribution of household size and by white and Native Americans. And you can see that the white communities have smaller household size compared to Native American communities, which you see kind of like a wider distribution, and they have higher household size. There's also a lot of multi-household kind of there's structured in the Native American communities, which also is contributing to the household size. And so here, if you plot the mean household size among individuals living in a tract and the proportion infected, in the household, you can see a very strong correlation between basically the risk and how your household size is contributing to your risk of infection. And as I mentioned, for this particular study, we weren't able to introduce another model. We just went with the model that we have and using the census data. And you can see that the proportions infected by white and Native American communities. And so you can see how the Native American communities have a larger risk and proportion of number infected in their community. So there's a strong positive relationship between the mean household size and the household exposure rate. And basically, this led to the higher incidence in Native American communities. And I mentioned before how, at least in New Mexico, the Native American communities have the highest household size across all the different races or ethnicities. Oh, sorry, going. Okay, so in conclusions, I think, household size was found to be a very strong driver of transmission, and which is, consistent with some of the studies that we've seen before. And I know that some states, I think in Washington, they were able to prioritize people that live in large household sizes during the COVID-19 pandemic. However, that's not a strategy that was used widely across the United States. Individuals employing high-risk industry tend to be disproportionately people of color, and at least that's what we saw in New York City. And we did prioritize, or during the COVID-19 pandemic, people in high-risk industries like public health practitioners, and were prioritized. But I don't know that it was applied to all industries, maybe some retail, etc. And finally, we also saw the school group size had minimal impact on transmission. So clearly the transmission may be coming from other areas. And so in terms of policy implications, we think that these studies will be able to help us explore in more detail and fine grain how different layers are contributing to disease spread. And so right now we kind of did, a study doing like just looking at household size and industry and then the schools. But in reality, everything is contributing to the spread. And so at least we kind of were able to kind of measure their contribution on the spread. And I have been working with some folks that are in social studies and in the social areas. And I have been kind of thinking about more of a multi-objective outcomes, as opposed to we usually tend to think about disease spread as a single outcome, which is, proportions of people infected or over deaths, but we're not really thinking about the larger implications of some of these policies, so including like social and also kind of the cascading impacts that some of these policies might have on different populations. And so I want to thank my team they have been working on this. And I mentioned that we have a paper that's coming out that is going to go into more detail about these three different studies. And that paper was led by Tom and Michaela. And we have also some other postdocs that are helping with this. And with that, I'd like to open it up for questions.
Well, thank you so much, Sarah. Thank you so much for the great presentation.
Sharing.
Yeah, if anybody has a question, I think you can raise your hand, or you can type it in the Q&A box. Maybe I will start with one question, if that's okay. This agent-based model has a lot of complexity, and you built it based on a lot of different data sources and various population characteristics. I think it's such a great tool that can be used for different diseases or different research questions. I was just wondering, what is your plan to potentially share the resources with the infectious disease modeling community?
So we are in the process of sharing some. I think that there's just a lot of approvals from our end, but our ultimate goal is to share it. But I think we're going to be kind of sharing pieces of the work. As far as this new paper is concerned, with kind of trying to understand the impact of demographics, we will be sharing a lot of the data so people could kind of play with the data. But the actual model, we're working on trying to share it, but the approvals are going to take a long time. But yeah, that's the goal.
Thank you so much. I think I see two questions in the Q&A box. So let me read the first one. Could you elaborate on the network construction process from the co-location data?
Yeah, sure. So because we're using the 12-hour time step as opposed to like an hour per hour. We do kind of an accumulation of all the interactions that you had during the day across the different activities. And so, for example, for kids that go to school, so you have your student teacher ratio, right? And so you have, let's say, 15 kids in your classroom. However, we assume that we have like a subgroup level. And so you might be just, you could be interacting with 15, you could be interacting more tightly with like 5. And so we have levers in our model to kind of explore that. And so basically you are drawing an edge with all 15 in the school setting, then but then you might have like a closer kind of intensity. We have an intensity kind of an intensity number that kind of captures that you might have more intensity with certain kids over others. At home, we also have all your home contacts. We also have the community contacts, and so we draw edges with a proportion of people in the community, although those edges are the intensity is lower. And at work, we also have this like group work groups, and so you're basically kind of drawing connections to different people depending on what activities they perform during the day, and also the community and the neighborhood that they belong to. And so that's more or less of the network construction. And one thing, just so you know, is that we're also, now that we have a lot more detail in the model, we're also trying to see if we can capture contact patterns by different demographic characteristics. And so that's something that we will be exploring in the future. And so the contact network is going to be super important for helping us estimate the contact patterns in the simulated environment.
Well, thank you so much. Moving on to the next one. It's a question. Oh, oops. Sorry, it's moving around. It's from Bedrick. I wanted to ask about computational efficiency, and also, for example, what is used for time stepping?
I'm not sure if the time stepping is every 12 hours, so I mentioned, and so I don't know if that answers that question, but the computational efficiency, I don't really have the numbers off the top of my head, but it's because we're using 12-hour time step, we can run in minutes, and for the whole United States, it's it's not as fast, but it's still very manageable because we're using the 12-hour time step. If we went to like every hour for 324 million, then it would get it would require a lot more computational resources. But right now, so it runs in minutes basically.
Wow, that's cool.
Yeah.
Yeah, thank you so much. The next question is from Serena. Thank you so much for the great talk, Sarah. Completely agree that the population heterogeneity is essential to capture for infectious diseases. I'm curious if you could talk more about the validation of the new model, either the construction of the synthetic population and contact patterns, for example, how attributes are assigned to individuals, and or the model fit and prediction accuracy to observed case counts.
Yeah, that's a great question. Validation is obviously super important. So the urban pop, which is a synthetic population that we're using in our model, that's a separate project I mentioned is from Oak Ridge National Lab, and they do a lot of validation of their models, and so you can also see some other papers in terms of the validation of the synthetic population. In terms of the contact patterns and how attributes are assigned to individuals. So in terms of the attributes being assigned to individuals, each individual in the census comes with attributes already. You come with like age, gender, and whether you're employed or not, and number of children and all of that. So all of that just comes from the census data, and the folks at Oak Ridge are able to use, I don't know if you're familiar with some of like the long surveys and short surveys to kind of estimate to estimate all the attributes by person, and so they're able to maintain the level of information that is provided at the more aggregate level, and they're able to kind of validate their synthetic population. And so in terms of the model fit and prediction accuracy. So that's now that we finally finish updating the model, now we're going to be moving towards validation, and we're super interested in kind of seeding the model with, now that we have data for the entire COVID-19 pandemic, we want to be able to validate it and see if we can capture some of the heterogeneity that we saw in the real world. Starting with, like in New Mexico, for example, can we see if the Navajo Nation had a larger number of cases at the beginning of the pandemic? And so now that we have the attributes, I think we should be able to do that, but we haven't done that, but that's where we're moving towards. Yeah.
Yeah, sorry, the next one is from Daniela. Very interesting. Do you think this model could be extended to other transmitted diseases like vector-borne, waterborne, and so on?
I think it could be extended. We haven't done that, but I think it could be like another layer of like just a vector-borne, and then you maybe add some level of risk. And so it would just be a few additional levers, I guess. And maybe when people are outdoors, they have higher risk than indoors. And so, but we haven't done that, but that's a great question.
Great. And the other one, thank you, a really interesting talk. I have two questions. One is, do you have any plans to add in age structuring within the household model? And the second question is, we can't run these models without making assumptions, but what would you say are the assumptions you'd most like to understand the impact of or perfect data available?
So we do have age structure within the household. Each agent in the household has it's comes with age, and so you do have like the parents are, you know, older, the kids are younger, and they do have an age structured. And obviously the contacts of the parents are going to be different than the children contacts. And so when they come and meet at when they're co-located in the home location, they obviously bring their exposure based on the activities that they perform throughout the day. So we do have assumptions that I like to understand are well, I think that we are making some right now. I didn't really talk, we didn't go into detail, or I didn't show any studies on behavior, but some of the major question for us is behavior within the population, emergent behavior, and how we can capture dynamic behavior in our models. And so I think so if we had perfect data for behavior, I think that would be amazing. We are also making assumptions about movement where kids go to school. For example, we're assuming that they're going in the same community, but there might be kids that go to a different community, and so we're aware of some of the limitations and some of the assumptions, but I don't know if they would be contributing tremendously to the impact. But behavior will be an important data set that we would like to have better data on behavior, and hopefully that can inform some of the dynamics that we're observing in the simulation.
Yeah, thank you so much. The next one is from Addison. Can you elaborate on the calibration methodology used for your research? Is it the ABC methods?
So calibration, we're not using the ABC methods. So I don't know if this is calibration of the studies that I showed today were kind of like hypothetical scenarios. They weren't really calibrated against real data. That's the one where we will be we'll be doing that pretty soon, now that we have the tools. But you do calibrate it. Basically, you seed the number of cases based on the data that you get from COVID, and so then you have to match basically your epidemic curve against the data that you have, and so you do have a lot of different kind of calibration methods. However, this study that I showed, they were just kind of hypothetical scenarios, and kind of like influenced by COVID-19, but not calibrated against like New York or Florida or New Mexico.
Thank you. Just one more question from Bedrick, which is, do you have a plan to scale up, maybe beyond the US? Or
beyond the US? Well, I don't think we have any plans in the near future. That would be a lot of data and a lot of computational resources. And I don't even know that we have the data available to do this ABM at the global level. I think the reason why we're able to do it for the US is because there's so much data. And well, there's a lot of data compared to other places. Obviously, we always want more data, so I shouldn't say like there's a lot of data, but yeah, we do have enough data to kind of develop these models, but globally, I don't know that I could go that far. But I know Alex has a global model, Gleam, and so it's probably doesn't have all these different things that we've been adding into our model, but I'm sure they may be thinking about expanding it.
yeah, I think thank you so much for answering all the questions.
Sure.
Any more questions from the attendees? I think we have just a couple of minutes, but maybe we can wrap up.
Yeah, this is great. I'm glad I get to chat with you more, Sarah. I have lots of questions, but I'll save them for later. So really great.
Okay, great.
Yeah, well, thank you so much again for taking your time to talk with us. It was really great. We really enjoyed your seminar. Thank you so much for your time. And thank you so much, everyone, for coming.
Thank you. And I'll see you around.
Thanks, Sarah.
Bye.
Thank you so much.